AIOS2025-GP55-ASNOS Symposium, where we are going to talk about neuro-ophthalmology in Asia. My name is Rashmin Gandhi. I practice neuro-ophthalmology in Hyderabad.
And I'm Dr. Carmen Chan, and I practice in Hong Kong.
I'm Dr. Engbo Wang from Taipei.
So we have a slight change in the order of presentation. We're sorry for that because of the commitments of speaker in some other rooms. So we now call upon Dr. Dipani from Sri Lanka, and she's going to talk about neuro-ophthalmology in Sri Lanka. Welcome, Dr. Dipani.
Welcome.
Bhaiya, last speaker.
Are you comfortable?
Yeah. Good afternoon. At the outset, I would like to thank the organizing committee, especially Dr. Rashmin Gandhi, for inviting me to do this talk. The patients' inflow into our clinics is mainly by the walk-in pathway. It comprises the bulk of our patients, both in other parts of general ophthalmology as well as the neuro-ophthalmology patients. There will be few referrals by physicians, especially in institutions without neurologists, and there will be some independent medical officers from peripheral units, and general practitioners will refer a few cases. Referrals by neurologists for collaborative care is a bit of a rare event in our scenario. So the commonest presentation at our eye clinics is loss of vision. The motility defects, there will be about 10 per year. Headache, of course, we don't have any number detected. We don't count them. Nystagmus and pupils mainly go to the neurology unit, and it's fairly rare for us to see. I had the chance of looking at the optic nerve disease. This is the bulk of our neuro-ophthalmology cases in our clinics. I had the chance to look at about 75 cases, and out of that 33 presented with disc edema, and 34 patients presented with disc pallor, whereas about 7 cases had normal discs. So the female to male ratio was the definite female preponderance in disc edema patients, 20 to 13, whereas disc pallor patients it was reversed, 14 to 20. Disc normal, it's a very small number, but still the females were much more. The majority of the disc edema patients were between 31 to 60 years. And then majority and the disc pallor group was a little older, about between 51 to 70 years. The normal disc patients was less than 30 years was the majority, whereas in other two groups the less than 30 years formed a significant but a smaller proportion in the age distribution. The commonest diagnosis was optic neuritis in all three groups, but we also had 2 SOLs among these 75 patients. The OCT and HVF was available in all these 100%, all these types of these presentations. The MRI and VEP was a little more difficult to get done because it is not available in the National Eye Hospital where I work, that is the main teaching unit. So we don't have an MRI and VEP for our use, but we do have an MRI across the road in the National Hospital of Sri Lanka. VEPs are even more difficult to get by because for the whole country we have about three institutions with VEP facility. And also the other problem is once, especially the optic disc edema patients, we diagnose, we start the IV methylprednisolone and then we send them across for further follow-up and further investigations. So sometimes we don't get the information back. In our education, in our MS ophthalmology, for our MS ophthalmology trainees, it is an essential component in our curriculum. Apart from the walk-in patients, apart from the assessment of walking patients, there will be 2 weeks pre-MD training in the neurology unit. And at the exit exam, we put more emphasis than the training, we put a lot more emphasis on the exam, because we believe that because it is the life-threatening nature of the conditions, we want them to be knowledgeable about these conditions. So the MCQs we consider as a very important part. So it's given an equal priority among the cornea, cataract and all the other subspecialties. Neuro-ophthalmology will be given an equal number of MCQs, and it will be also one or part of the 4 SCQs. And we also have a separate section in clinicals, allowing 30 minutes for each candidate to see about 3 to 4 cases. And the examination will be conducted by a panel consisting of an ophthalmologist, a neurologist, as well as the external examiner from a foreign country. We also recently started a degree course in optometry. We used to have ophthalmic technologists, but we have about 2 batches now of doing the optometry degree. In their curriculum, we have included 4 lectures in neuro-ophthalmology, and 4 out of 25 hours dedicated for ophthalmology is for neuro-ophthalmology. And their examination, we only ask MCQs. We have a lot of challenges more than achievements. We don't have board certified neuro-ophthalmologists. Only few of us general ophthalmologists are interested in pursuing the cases of neuro-ophthalmology. There is a very high expectation among the administration as well as among the patients regarding the cataract output. A hospital's work is assessed by the number of cataracts they do. And because the longer time needed to assess neuro-ophthalmology patients, it is not very attractive to eye surgeons. They prefer to refer to the neurologist after a very quick assessment. Since the back referral is not mandatory, we don't see the outcome of the patients we have diagnosed. And also, it's not only the back referrals, it's not that the neurologists don't make the back referrals, but the patients do not come they don't like to come to our clinics because of the very high patient inflow. The investigations are not available in all the hospitals below the teaching hospitals. Most of the teaching hospitals generally have the investigations, but other hospitals there is a the availability is very difficult to like it's very in a haphazard way the investigations are available. So to mitigate these challenges, we have convened a neuro-ophthalmology interest group, which was inaugurated in May 2023, only 2 years old yet. The members are mainly the interested ophthalmologists and neurologists, but we also have invited pediatric neurologists, neurophysicists, neurosurgeons and radiologists who are doing MRI in the main hospitals. Our objectives were the most important objective was to ensure providing collaborative care for the patients, because we noticed that the lack of it has caused sometimes poor outcomes, and also to improve the knowledge and skills of the candidates, of ophthalmology candidates at the exit exam. Our main activities planned were the case-based discussions shared online, like a video library and case library. The cases are accumulating very slowly over the last 2 years. And also organization of half-day annual academic meeting or symposium on a selected theme or a topic. This has been happening even earlier, but now it is the duty of the neuro-ophthalmology interest group to organize that. And also to organize training workshops for postgraduate trainees, mainly for ophthalmology, but sometimes the neurology also. Just like a lot of neuro-ophthalmologists today claimed, we get very little financial support. So all these meetings mostly will be on Zoom. But we are going to have a physical workshop to prepare recommendations for vision preservation of patients with headache and those undergoing surgery for brain tumors. That will be in the end of this month. And this will be done in collaboration with the College of ENT Surgeons and associations of neurologists and neurosurgeons. There will be lectures and case discussions followed by a discussion on the recommendations for this vision preservation. And we are planning to produce a common document which will be reviewed, edited by the senior, and we want the junior members to join us. And this will be given to the non-communicable disease unit of the Ministry of Health to be shared with the relevant medical communities. Thank you so much for your patience listening.
I wonder if there's any comments or questions for Dr. Dipani, because she might be leaving earlier. If not, we will proceed to our original first speaker, Professor Zhongming Huang from Seoul, and her topic will be Neuro-Ophthalmology in South Korea. Professor Huang, please.
Thank you for your introduction, Angwa, and good afternoon, colleagues. I appreciate Dr. Kashi for the invitation to talk about neuro-ophthalmology in Korea. No conflict of interest. We have two neuro-ophthalmology societies in Korea, one led by ophthalmologists and the other by neurologists. Korean Neuro-Ophthalmology Societies were founded by ophthalmologists in 2009 and by neurologists in 2010. Our KNOS has 122 members and the KSNO 973 members. From now on, I will talk about KNOS. KNOS has had 8 presidents, me the first. Now the 8th president, Dr. Kim Hae-young, is working for us. Our society has a whole-day workshop in April and another whole-day symposium in September. In addition, we have symposiums, lectures, paper, poster presentations at the biannual meeting of Korean Ophthalmological Society. Our website has been updated with news, disease information, review of the recent papers, and interesting and difficult cases. These are the books published by our society, and on the right, the books published by neurologists. In 2017, we hosted the 9th ASNOS meeting in Seoul. It was KNO's first international conference. I served as the chair and Dr. An at advisory board, Dr. Kim Eung-soo working as a general secretary, Dr. Shin Hyun-jin and other members contributed to the meeting. I also appreciate the international ASNOS members for their contribution. I will introduce studies from Korea. The health insurance enrollment rate in Korea is nearly 100%. Many researchers, both in Korea and internationally, use the Korean National Health Insurance Service database. We found an association between several small vessel disease and NION. Cataract surgery increased the risk of NION. NION did not increase the subsequent risk of stroke in the general population. Obstructive sleep apnea increased the risk of NION, although the absolute risk remained low. Research to find biomarkers of inflammatory optic neuritis in Korea suggested that serum GFAP reflects aquaporin 4 optic neuritis status and severity, and serum BDNF is a prognostic biomarker. Regarding optic neuropathy, Pupillary constriction latency was delayed more in optic neuritis than in NAION. Decreased light reflex recovered in the chronic phase of optic neuritis, but not in NION. A multicenter retrospective cohort study showed that pediatric optic neuritis was associated with MS, NMOSD, and ADEM in 41%. The incidence of ethambutol-induced optic neuropathy among Koreans were 0.7% and can be reduced with lower doses. Regarding LHON, childhood LHON showed a higher proportion of subacute or insidious onset of symptoms, better visual acuity, higher spontaneous recovery, and asymmetric ocular involvement. The visual prognosis of Korean LHON 3460 mutation was generally poor. Only 10% showed visual improvement to 2050 2 years later. The spectrum of mtDNA mutation in Korean LHON is characterized by high prevalence of 11778 and 14484 mutations, and a lower prevalence of 3460 mutation. As another contribution to neuro-ophthalmology, we developed optimized imaging protocol for better visualization of cranial nerves. Third, fourth, and sixth. We found that CFEOM may be associated with third nerve hypoplasia, and while synergistic divergence associated with sixth nerve aplasia. In CFEOM with synergistic convergence, also CFEOM with third nerve hypoplasia, and synergistic convergence with sixth nerve aplasia. We found absent sixth nerve in all of type 1 and part of type 3 Duan, and present sixth nerve in type 2 Duan. Similarly, Melville syndrome also showed sixth nerve aplasia and seventh nerve aplasia in the most. It takes several years for us to visualize the fourth nerve because of its small size and its horizontal course parallel to the imaging plane. Imaging of the first nerve requires three conditions. First, 3 Tesla system. Second, in oblique axial direction. And lastly, a slice thickness of 0.25 millimeters. We found that 3/4 of congenital first nerve palsy showed first nerve aplasia. We tried to predict the absence of first nerve based on superior oblique volume. The cutoff value for the paratic to normal side superior oblique volume ratio in predicting first nerve absence was 0.75 or lower. We hope that neuro-ophthalmology in Korea will continue to grow, and Korean neuro-ophthalmologists will become more involved in international societies. Thank you. Dhanyabad.
So thank you, Jumi. Do we have any questions for Dr. Huang? Yeah.
Well, actually, this is a comment, and we really appreciate your contribution to the Asian neuro-ophthalmology. And you have been producing cutting-edge research and studies on neuro-ophthalmology. And whenever I find something interesting, those papers are always from your country, and including your name there. So definitely you are leading neuro-ophthalmology researchers and clinicians in Asian countries. I really appreciate your contribution to the neuro-ophthalmology in Asia.
Oh, thank you so much. Thank you.
Jiaomi. And Ansu, both of you.
I think congratulations for Professor Huang's excellent talk and great achievement. And I have one question for Professor Huang, that you reported that the lung disease with 3460 mutation, they have only 10% of chance for spontaneous recovery. And however, on the other hand, Neuro study showed that 3460 have a poor response to idabinone. And in that condition, how would you suggest the use of idabinone in patient with 3460 mutation?
I think that based on the studies performed, so I think it would not be better to prescribe the idabinone in 3460.
So you personally think that should not be recommended to them?
Yes, based on the
But
previous
in
studies.
Asia, that spontaneous recovery rate is so low, would you consider to maybe explain the condition to the patient and let them choose whether to use it or not by themselves?
Maybe I think I would be better to explain the result of the previous studies and let them decide whether they would take the medication or not.
And another question is that, is the idabinone being approved in Korea now, or by the Korean FDA? Is that approved yet?
Yeah, it's very hard. We are having a hard time to prepare the data for idabinone for LH1 because the previous company presented the 900 patients data for the FDA approval. So I think it will be very difficult to make the 900 patients. So
In near future?
Yeah, very, very hard.
Okay,
Yeah.
thank you. Thank you for
Thank
your
you.
wonderful talk. Thank you.
Shall we take this opportunity to invite our next speaker, Dr. Muhammad Sadiq, who is going to talk to us about optic neuritis spectrum disease in Indonesia.
Thank you. Thank you, Dr. Carmen, and good afternoon, everyone. First of all, I would like to thank to the organizer who had been inviting me to give the opportunity to speak in this precious moment. I will talk about neuro-ophthalmology in our country, Indonesia. Neuro-ophthalmology is not so popular compared to other fields in Indonesia. Until now, there are 18 neuro-ophthalmologists and 18 fellow ophthalmologists who had been trained for neuro-ophthalmology in Indonesia. They are spread on 12 provinces hospitals all over Indonesia. All of us are gathered in a society called Indonesia Neuro-Ophthalmology Society. This map shows us among 38 provinces, only 12 provinces have neuro-ophthalmologists. We could see here on the map, white dots are areas that have neuro-ophthalmologists, gray dots are fellow, and black dots are provinces without neuro-ophthalmologists. However, even our community is small, we think that a lot of things we could do in order to solve the problem in neuro-ophthalmology in our country. I will share with you a little bit of experience about optic neuritis management. Several clinical guidelines for optic neuritis management in our hospital have been compiled. Initially, we use it for our patient in the hospital, and then we share it to other colleagues at the other hospitals. Hope that we have similarity on the management of the diseases. From our society members, based on online survey regarding their experience in managing optic neuritis, On average, they had around 40 patients with optic neuritis per year they manage. We have several diagnostic examination that could be done in hospital, and it depends on availability of devices and machine on each hospital. Also depend on the affordability of patient, because not all examination covered by national health insurance. Some of the examination are covered by national health insurance, some are not. It means that if the patient needed to be performed certain examination, they have to pay the cost from their pocket. It also occurred for the laboratory tests and imaging examination. Some of them are not covered by national health insurance, while the others are time constrained. For example, for imaging examination, for brain imaging examination, if they want to be covered by national health insurance, sometimes the QE waiting time sometimes until several months. So of course, for certain disease, it could affect the prognosis of the disease. These are examples of what is covered and what is not covered by national health insurance in our country. This just want to show you, and on this slide we can see how much if patient have to pay from their own pocket if they want to do certain examination. For example, if they want to have brain MRI examination, they have to pay around $200 US. Now back to optic neuritis. Unfortunately, currently we still do not have nationwide data regarding optic neuritis in our country. However, some hospitals have published the database for their own. For example, this is the data from Manado City, Bali, Bandung, and Jakarta. It is from several provinces in our country. Our hospitals, Cipto Mangunkusumo Hospital, located in Jakarta, is the top referral hospital. The data collected from optic neuritis patients are described here. From year 2018 to 2020, we have 168 patients of optic neuritis. Female are more than male. Most is between 18 to 50 years old, and around 60% are typical. Below is our illustration of several cases for our clinic, but not only optic neuritis. Also, I do also share with the other case. Case number 1 is 40-year-old female with blurred vision of both eyes. She felt that the vision of left eye gradually decreased since 2 years, while the right eye, the vision decreased since 14 years ago. This patient was consulted to our clinic from neurology department. On anamnesis, in our clinic, she confessed of blurry vision, first on the right eye and then followed on by left eye. On examination, we found visual acuity of right eye was light perception, and left eye is 1 meter finger counting. RAPD of the right eye and optic disc atrophy on both eyes. Visual field of left eye was severe, generally depressed. VB examination resulted on prolonged latency of both eyes. Laboratory test for NMOSD was done, and the result was positive, and also positive for anteater. Brain MRI showed suspicious pontine melanolysis, and we conclude this patient have both optic disc atrophy because of NMOSD. Patient then start treated with immunosuppressive agent given by the internal medicine specialist. However, the visual acuity remains stable, perhaps because of optic nerve had been atrophy. The next case is a female, 21-year-old, who had blurry vision on the left eye, accompanied by pain with eye movement. Clinical examination showed visual acuity of right eye is 6/6 and left eye is 6/18 with normal fundus appearance on both eyes. Diagnosis was made as typical optic neuritis, and blurry vision was resolved following intravenous corticosteroid injection. However, Further imaging examination showed sign of multiple sclerosis and left optic atrophy. Even the visual acuity was back to normal, 6.6, OCT examination showed thinning of retinal novation layer. Patient then treated with immunosuppressive agent. The next case, case number 3, is a male, 43-year-old, had sudden blurry vision on both eyes. 4 months, first on the left eye and followed a week later on the right eye. Visual acuity on both eyes was 640. Brain CT and MRI that have been done at other hospital were normal. Laboratory tests work up on our clinic showed reactive result RPR and TPHA. And further clinical examination resulted diagnosis of bilateral posterior uveitis and bilateral atypical optic neuritis, presumed caused by syphilis. Patient then treated with benzathine penicillin by dermatovenerologist. Case number 4 is a male, 71-year-old with blurred vision, swollen and protruding of the left eye, followed a week later by right eye. He had history of diabetes mellitus and hypertension. Visual acuity was hand movement of left eye and no light perception of the right eye. Ocular movement were restricted to all directions. Blood laboratory examination was unremarkable except increased blood sugar and D-dimer and decrease of liver function. Leukocyte count was within normal limit, but PCT level was increased. Orbital CT showed bilateral cavernous sinus thrombosis. Both lateral nerves were both optic nerves were compressed by thickening of recti muscle. Patient then was treated as septic cavernous sinus thrombosis, and disease resolved within weeks. However, visual acuity didn't back to normal because of optic atrophy. And this is the last case, is a male, 55-year-old with blurry vision of both eyes. He had history of diabetes mellitus for 10 years and laser photocoagulation on both eyes for diabetic retinopathy. Visual acuity of both eyes were half-meter finger counting with both papillary escape and immature cataract. Fundoscopic appearance showed normal, optic disc and laser mark on the retina. OCT macula showed thinning of the GC IPL. Normal radiologic finding on brain imaging examination. And please observe these pictures. These two pictures of patients showed the difference of skin color between the time when patient came to our clinic and 1 year before came to our clinic. We could see here how the color of skin significantly changes within months. We could see here hyperpigmentation spot on his face. And further exploration resulted that patient had pulmonary tuberculosis in last 18 months and was treated with linezolid. So the patient was diagnosed as toxic optic neuropathy caused by linezolid. That's all our case. And I show you the activity of our society. We did some webinar, didactic course, and also public education, and also some publication. We have a publication of Neuro-Ophthalmology. We asked our colleague neurology from other area, other province to send them in interesting cases, and then we could publish on our journal. Maybe it could, maybe some other ophthalmology can learn from this publication. And we will do AIOS meeting in June 2025. Thank you. And I would like to thank to my team, Dr. Cynthia, Dr. Salmar, Reska, and Dr. Sita, who helped me to prepare this slide presentation. Thank you.
Are there any questions from Dr. Mohammed? Thank you so much, Dr. Siddiq. And now next we have Dr. Karen. and she's going to talk about neuro-ophthalmology in Philippines.
It's not okay there. Okay. I would like to congratulate the organizers for this
D
beautiful
postoperative care
symposium.
and rehabilitation. IC611, pediatric cataract.
Oh, there's
May 4th,
AI.
2025.
Me versus AI. Okay. Okay. Thank you. Thank you. So I will now discuss neuro-ophthalmology in the Philippines. So to help me with this lecture is Dr. Giancarlo Narag. So as usual, I have nothing to disclose. So the Neuro-Ophthalmology Society of the Philippines, that we call NOSP, currently has 45 members to serve the Philippine population of 108 million. So we have a Philippines healthcare system called the PhilHealth. It's shared by both public and private sectors. It was just a recently enrolled Republic Act. However, this Republic Act is mostly basic care, so cataract. So in 2024, cataract extraction ranked as top 8 for PhilHealth claims. And is it useful for neuro-ophtho diseases? Not really. So there are the patients who can afford the diagnostics for our diseases. They usually either have to pay on their own, or they have their own private insurance, private HMO. So the epidemiology of neuro-ophthalmology in the Philippines is, in 2002, the prevalence of visual impairment in the Philippines is 4.62% of then an 80 million population. In 2011, the prevalence of the NO diseases in the NCR is 3.37 per 100,000, or 6 NO consults per 1,000 general ophtho consults. So I think it got better. In 2011, this was presented by Dr. Lourdes Ang in Kobe, Japan, in ASNOS. This won a travel grant there. In her prevalence data, the top 3 causes were secondary to ischemia, then trauma, then unknown. Fast forward to 2024, this was the census of our main referral tertiary hospital, the Philippine General Hospital, where, strangely enough, we see a lot of compressive cases, a lot of pituitary adenomas, followed by ischemic causes, optic neuropathies, or your efferents, your palsies, and again, unknown etiology. And the frequently encountered conditions, comparing it to 2011, we saw oculomotor nerve palsies, 6 nerve palsies, and dramatic optic neuropathies. Now, fast forward to 2024, we see a lot of optic atrophy. These are the late referrals. We see them with the pale nerve, and the history and their onset was 2 years prior, 1 year prior, and that's why they're the leading cause of consults of last year. And again, compressive optic neuropathies, most of them are pituitary adenomas. And the third ones are the ischemic optic neuropathy. Well, it's nice that the traumatic optic neuropathy is not even in the top 5, because I guess most of our countrymen are now wearing helmets when they drive the motorcycle. Okay, and so our diagnostics for the MRI machines, we really need the imaging. So we have 123 machines in the Philippines concentrated within the urban areas. Unfortunately, most of them are private hospitals. And CT, we don't have a specific data, but most of the time, if there's a tertiary hospital, there should be a CT scan in there. For the OCTs in the visual fields, there are about 1,683 eye care centers. And unfortunately, most of them are cataracts. They're like cataracts within the Philippines, with variable availability of the ophthalmologic diagnostic tools. So where are we? The 45 NOSP. We call ourselves the NOSPers. We are mostly located in Metro Manila. In Manila, we have a few, one there in Luzon, in the Ilocos area, and then like maybe around 10 neuro-ophthalmologists in the the Visayan area, the Cebu area, and now we have one in Mindanao. So we still need to train a lot more to serve the underserved areas. So these are challenges. So we have limited specialists in the country, especially in the underserved areas. So we need more training programs. And do we have a role in telemedicine in improving access? I guess we have, because some of my patients, they find it useful when they're in the province, and then they update me with their follow-up, so we can just coordinate. For me, I'm still a go with telemedicine, and it's used for neuro-ophthalmology. And again, the resource constraints, especially in the rural areas. They can't be imaged using an MRI, so that's a challenge. And again, the healthcare disparities. If you don't have private HMOs, if you don't have access to that, you get to have optic atrophy in a few months. And there's the economic challenges too. So the neuro-ophthalmology in the Philippines is still within its maturation stage. The Philippines has multiple potential opportunities for research and training. So these are my references, and thank you. The APVRS will be held at the end of the year in Manila, and we do have neuro-opta session. So we have a session on diplopia and on vision loss in a normal pairing fundus. See if you want to come to Manila this year, and I guess I will see you in 2028, in APAO 2028. Okay, thank you.
Thank you, Dr. Reyes. So next up is our dear friend, Dr. Clementine from Singapore, who is going to talk to us about the neuro-ophthalmology in Singapore.
I always get a little embarrassed when they ask me to talk about neuro-ophthalmology in Singapore. There are only 6 million people in Singapore, and when Dr. Siddiq said there are 18 neuro-ophthalmologists in Indonesia for 282 million, I just feel embarrassed. We have 18 neuro-ophthalmologists for 6 million people in Singapore. But we do face one small challenge, which is the declining interest in doing neuro-ophthalmology. And I think I'm trying to learn from others, especially those in India and America, about how, and Hong Kong, about how putting neuro-ophthalmology together with other disciplines may help sustain the practice of neuro-ophthalmology, because if not, we have a major challenge. So I thought today to talk about an emerging what possibly is an emerging problem in Singapore, and maybe for the rest of us in East Asia as well, and that is myopia and optic neuropathy. I wish I had an MRI scanner. Then I could disclose I had a financial disclosure. And Singapore likes to think it's very good in many things, and we are top in number one for many things. So we always, for a long time, we said we are number one in myopia prevalence, but it's not really the case. And there's plenty of myopia in Japan, in Taiwan, in Korea, and in China. So something is happening out in East Asia. We just have a lot of very short-sighted people, right? But I don't know if any of you have paid attention to the International Myopia Institute and how they define pathologic myopia. Because in the definition for pathologic myopia, there is one small line, high myopia associated optic neuropathy. It is actually there. However, in the graphic on pathologic myopia, there is no optic neuropathy. And I've been asking the myopia people, why have they not included it? And the challenge really is that the definition of this condition is still not quite robust enough. It's a little bit uncertain, right? It is a little bit uncertain. What actually is this optic neuropathy? Is it just glaucoma, or is it a unique optic neuropathy of its own? And in fact, there may actually be both glaucoma and a unique optic neuropathy that's unique to high myopia, right? And if you look at the Beijing Eye study, they had 9% of their patients with moderate to severe vision impairment or blindness that had optic nerve atrophy, of whom they could say that 5 were glaucomatous, but 9 of them did not appear to be glaucomatous at all. So, and if you have very high myopia, then you have a high risk. You seem to have a high risk of having an optic neuropathy, and I think we are beginning to see this more and more. And certainly, I'm beginning to see more and more of these patients with very high myopia and what is an optic neuropathy. So what do we know? It coexists with myopic maculopathy. There is an enlargement and a misalignment of the optic nerve head, together with elongation and thinning of the lamina cribosa. Those of you who've read some of the work on glaucoma know that there's this challenge of translaminar cribosa pressure difference, which is the difference between your CSF pressure and the intraocular pressure. But there's also shifting and enlargement of Brooks membrane, and you have these very interesting different zones. So a lot of the definition of the optic nerve and the appearance has largely been based on photos and OCTs, and not so much on function, right? So we are down to having a glaucoma-like and a non-glaucomatous-like optic nerve damage. So I had a look at some of our patients, and we've been looking at patients who had been suspected of not having normal tension glaucoma, and I pulled out the patients with high myopia to see what the electrophysiology was like compared with the others. And about, in this group of patients with presumed NTG, about 40% of them have a delayed pattern VEP peak time, which is thought not to be characteristic of glaucoma. And in this group, if you look at the myopic, if you look at them, they have those with N95 abnormalities and those without. And those without N95, I beg your pardon, those without N95, those with N95 abnormalities may also be seen in pattern VEP with no delay. And that group circled in green there is probably more likely to be glaucoma, and the ones that are with a delayed peak time may not actually be glaucoma. So what about the highly myopic individuals? If you look at the highly myopic individuals, nearly all of them who had a pattern VEP delayed peak time also had a N95 abnormality. Now, this may seem to suggest that it's not all glaucoma, but on the other hand, could not a very severe glaucoma have a delayed peak time as well? The other challenge, of course, we have is when we look at the disc. Now, of course, there's a temporal raphe sign, and I think there's a lot of there is some very good literature on this coming out of Korea. So thank you, Jongmin and all for supplying some of the information on, and the Koreans for supplying this temporal raphe sign. And it may help or it may not help. And I will show you a case in point, right? This is a relatively young woman, very, very, very high myope, -13, who had LASIK done. And then after that was discovered to have a superior visual field defect in one eye with an afferent pupillary defect, but still normal 6/6 vision. The MRI scan that was done for her, in which she was found to have an afferent pupillary defect, just showed an atrophic left optic nerve, nothing else, just an atrophic nerve. And the other nerve was thought to be normal. And her IOP, of course, post LASIK was a bit low, right? Was low. This was what her visual fields looked like, and you thought, well, maybe isn't this just glaucoma, right? Isn't this just glaucoma? And she was treated as such, right? But when you look at the disc again, it's really hard to be absolutely sure of the cupping. And if you see the OCTs, there is this deformed appearance of the optic nerve that makes it really hard to characterize it. These are her optic nerves showing staphyloma, as well as the thin left optic nerve. We did her electrophysiology, and at that time she had a borderline delayed pattern visual evoked potential, as well as a reduction in N95. So that seemed to be consistent with glaucoma, and she was treated as such. But she kept getting worse. She didn't come for follow-up for a while, and then she seemed to get a lot worse with the visual fields in the eye. Note that the right eye is still completely normal at this time, right? And you can see here that there is no temporal raphe sign in that left eye. And in the right eye, it looks like in the macular GCIPL layer, there is also some thinning. And you wonder whether this is just because the patient is just a high myope, and so their retina is just thin overall anyway, and you will not be able to get a good sign. But this highlights one of the problems with these patients with high myopia. We repeated the MRI again, nothing much. Autoimmune workup, interestingly, showed some anti-optic nerve and anti-retina antibodies. That said, those with myopic maculopathy have also been found to have some anti-retina antibodies as well. This time, the electrophysiology found that not only was the left eye very markedly delayed, much more than the pattern ERG would suggest, but the right eye also had a delayed pattern VEP despite its normal visual fields. We did try her on a course of steroids, and you can see that for the period that she was on steroids, the visual fields seemed to be pretty stable, but she couldn't tolerate the side effects. Eventually developed a bit of steroid-induced cataract. We had to take those out. And then after the steroids were stopped and all, she again had another decline in her visual fields and then stayed stable again. This despite trying to maintain a good low intraocular pressure. So this is a challenge when you have a high myope with what looks like an optic neuropathy. Is it glaucoma, not glaucoma? What do we treat it as? The structure is challenging to use as a diagnostic tool. Function may help a little bit if you have some electrical function to test, but that's again something that we're not so sure about yet. And maybe we'll have to think about the translaminar cribosa pressure difference. Is that a new frontier for us as neuro-ophthalmologists to look into? Patients with very deep cups and a very thin laminar cribosa. Is there an autoimmune inflammatory component? And is there a way to actually treat pathological myopia? And with that, thank you very much for your attention.
Thank you, Clement, for that very interesting talk, because of course in Hong Kong as well, we have lots of patients with high myopia, and that situation is, I encounter that quite, not uncommonly, and it's quite difficult to tell whether it's, we need some further discussions after the session. So, shall I let you introduce the next speaker?
Yeah, our next speaker will be Nifong Chirapaisan, and Professor Nifong, please.
Good afternoon, ladies and gentlemen. I would like to thank you, Dr. Kachai and ASNOS committee, to give me an opportunity to join this session. Last year, there was an outbreak in Thailand. It involved about 28 patients who consume illegal alcohol. 2 patients died. 13 intubation, 18 dialysis, and 6 need cardiopulmonary resuscitation. The clinical presentations involve metabolic acidosis, respiratory distress, acute renal failure, seizure, loss of consciousness, and visual loss. As in Laos, 6 foreign tourists died, with more still blind after consuming illegal alcohol contaminated with methanol. Raising concern about how such tragedy happened and extent of methanol poisoning as a widespread issue. According to statistic data, methanol toxification is the most prevalent in developing countries, mainly affecting people in low economic societies. Southeast Asia has the highest prevalence of methanol poisoning globally, with reported incidents in Indonesia, Cambodia, Vietnam, the Philippines, and Thailand. Methanol is clear, colorless, and odorless liquid. It's widely used in many industrial sectors. Many methanol poisoning happen because people drinking illegal alcohol contaminated with methanol. Another circumstance is occupational exposure. Chronic percutaneous or inhalation exposure may cause serious consequences. When methanol enters the body, it's rapidly metabolized into formaldehyde by enzyme alcohol dehydrogenase. Formaldehyde is then converted into formic acid, a highly toxic substance, by enzyme aldehyde dehydrogenase. Accumulation of formic acid develops metabolic acidosis with secondary systemic complications. Formic acid also inhibits mitochondrial cytochrome C oxidase, causing ATP deficiency. The optic nerve and retina are highly sensitive to oxygen and ATP deprivation. The methanol metabolism and oxygen deficiency produce free radical, which damage the optic nerve and retina. Additionally, formic acid also damage myelin sheath, causing visual loss and potential permanent visual loss. Systemic manifestations of methanol intoxication include CNS symptoms such as weakness, loss of consciousness, and convulsion. Systemic metabolic acidosis symptom, visual loss, GI symptom, renal failure. Consequently, death may be occur. Methanol optic neuropathy usually presented with bilateral symmetrical and severe rapidly progressive visual loss. Anterior segment examinations are usually normal. Pupils are dilated and unresponsive to light. Bilateral optic disc swelling and retinal swelling may be observed. The MRI showed T1 enhancement and central hyperintensity of the optic nerve. The retrobulbar part is the most affected. For the OCT, the retinal nerve fiber layer slightly increased in the early stage and decreased afterwards. But retinal ganglion cell layer decreased dramatically in the early stage. Therefore, the retinal ganglion cell layer is more sensitive than the retinal nerve fiber layer. The treatment of methanol intoxication requires multidisciplinary medical team, including emergency physicians, ophthalmologists, and toxicologists, to ensure comprehensive care and minimize severe complications. Methanol poisoning affects multiple organs due to metabolic acidosis. Treatment includes bicarbonate administration and hemodialysis to restore acid-base balance. Omeprazole and ethanol is used as an antidote. Folic acid or folinic acid enhance the elimination of formic acid and reduce cellular toxicity. Treatment of methanol optic neuropathy don't have well-defined guidelines. Some reports suggest that systemic corticosteroid and erythropoietin may help to improve vision due to their neuroprotective, anti-inflammatory, antioxidant, and anti-apoptotic effects. Many people don't know how dangerous methanol poisoning is. Illegal or homemade alcohol can contain methanol, which is highly toxic. Drinking it can cause blindness or even death. Since people are unaware of this risk, they may delay getting medical help, making their condition worse. Another big problem is the lack of regulation. Many countries, illegal alcohol is not controlled, so people don't realize the danger. On top of that, public health campaigns don't get enough funding, making it hard to spread awareness. To prevent methanol toxicity tragedy, we need better education, stricter regulation, and more public health initiatives. Awareness can save vision and life. Thank you.
Thank you so much. Are there any questions or comments about that presentation? Now I'll invite Professor Rohit Saxena to talk about neuro-ophthalmology in India. One word about Professor Rohit. This massive conference obviously has been organized by APO and AIOS, but the third society which has been the host society is Delhi Ophthalmological Society, and Rohit is the current president of Delhi Ophthalmological Society. Thank you, Rohit.
Thank you. Thank you, Rashman, for the kind words, and thank you, everybody, for coming to the APO AIOS here in New Delhi. Do not please get you know, misguided by the numbers you're seeing here. This is not the kind of response you'll see in a neuro-ophthalmology conference. So that, of course, brings me to the issues that we have faced. And this was something similar I had spoken last time also. So to be honest, I didn't have to make too many changes because really neuro-ophthalmology in India has not changed. We still have the same issues and the same problems, but of course, some things change while they remain the same. And as I always say, in neuro-ophthalmology, I unfortunately have no financial interest to disclose, but I'm still keenly searching for some. So neuro-ophthalmology in India, we have some of these stalwarts who've actually significantly contributed and are my personal mentor, Professor Vimla Menon, whom after a great bit of resistance from her part, we were able to give her the Lifetime Achievement Award in the last AIOS conference. When she was the president, she refused that it will not be appropriate, and thankfully after that, unfortunately, she couldn't come to the last conference we had in Shankar Nethralaya, and we had to give her at home. So she's one of them, but of course, we've had a plethora of some fantastic people. Unfortunately, I think in India, like it is in a lot part of the world, anything behind the lens is the realm of the retina surgeon. So a lot of these patients land up with the retina person who gets an OCT done now and says that retina is absolutely fine. I don't think I need to do anything about it, and they send it back to the neuro-ophthalmologist. So that's how we get our great referrals that we do, and it's our job to find out whether the patient fits into neuro-ophthalmology, or they may have keratoconus, they may have lenticular changes, they may have retinal changes, which may be a little subtle to pick up early for the OCT. But these are the doyens of neuro-ophthalmology who've taught us what we know, and because of their massive contribution, today we have a large number of institutions, including Arvind, Shankar Nethralaya, SGPGI, LV Prasad, Guru Nanak, Narayan Nethralaya, PGI, and of course RP Center, who have significantly contributed to the bulk of work and the interest this specialty is now started generating in India. So we have over 300 members at present. In fact, it's touching 340 now, for a society that started in 2018. So that's the movement of Indian Neuro-Ophthalmology Society that is there in India. There is definitely, as some of you would have encountered in your possible visit to the AIOS whenever we've had a fair bit of interest, and people have some very interesting cases to present, and the conferences are getting more vibrant, more interesting, and of course, thanks to a lot of international faculty who are present here, who make the discussions absolutely fantastic. So it's one conference in neuro-ophthalmology I would recommend. This year, in 2025, our 7th conference would be in Jaipur. So of course, it has beautiful palaces, lovely place to visit. It was made very popular by the destination wedding of Angela Jolie and Brad Pitt. Whatever the result was, I'm sure Jaipur had nothing to do with that. But yes, they chose Jaipur to be the venue, and I can assure you, you come with your partner and you will have a great feeling about relive your early days of your marriage. But Jaipur is otherwise, of course, a beautiful city, and we welcome you to the AIOS. It's in the 6th and 7th of September this year. And next year, we as a society are very grateful that we are getting the opportunity to host the ASNOS in India. The planned dates are 26th, 27th of September. We'll of course be conveying it officially, but these are our tentative dates. We plan to hold it in New Delhi. Many of you may be staying in the Aero City hotels, and that's the place where we are planning to hold the conference, so that people are just there and they just need to walk down and they don't have to look at the lovely Delhi, pollution and the traffic. So of course, you can always take a visit out and experience whenever you want to, face some challenging situations in life. So that's a much recommend. So of course, we'll welcome you again this year and again next year. We hope that we have a great conference. We'll work with ASNOS to make it a very, very big conference. And of course, our team, of course, Rashmin, who was among the pioneers who actually discussed with ASNOS and ensure that we have the ASNOS in Delhi. Really looking forward to, and we hope we'll have a lot more members and a lot more interest. So as I said, block your dates. This is the executive committee that we have currently, and they are really working. They are the full team for which we are really working every year for the conferences, and of course now preparing for the next one. Some of them are here, and many of them you would recognize. Ambika is here, Rashman is here. So these are among our stalwarts who've helped us to build this society. That's the website page where we try and display some cases, but it starts getting dated after a while. The AIOS is constantly working on activities of educational material, webinars, workshops. Some of you may have interacted in some of the webinars that we've had. We try to make them very interactive. And again, as I mentioned, it's our international faculty that help us to take the level of our discussions high. We have platforms for presentation, especially for residents and fellows. There is a fair amount of case presentation format which we do, and we are looking forward for future collaborations with international societies, especially for research. So I would say that ASNOS is in the best position to try and get Neuro-Ophthalmology of Asia together. I remember the days in the early 2000s when we used to present optic neuritis in Asia, and all of us used to say that, you know, Asian optic neuritis is a bit different from what ONTT keeps teaching us. And I think over time we realized that we have a lot more NMO in the Asian population. We sure do in India. So it's a different set of patients that we see here. Many of them don't do so well as their American counterparts or the European counterparts. So I think it's time that we, you know, made a subset of our a research group which could probably collaborate to work on interacting with each other and working. So these are some of these awesome conferences that we've been having. Shankar Netralaya hosts some wonderful neuro-ophthalmology conferences, Ambika here, and of course, like I said last time, last neuro-ophthalmology conference was in Shankar Netralaya. So again, the society, with whatever few members we are, is pretty vibrant, and we try to, you know, kind of hit above our weight. The other thing was that last year we managed to get, so FICO is an exam system. It's a certificate exam system held by the AIOS, which has over 28,000 members. And till last year, they never thought neuro-ophthalmology had, you know, any takers, so they never kept neuro-ophthalmology in the list. But last year, we were able to push them to start a neuro-ophthalmology FICO. Last year, 5 people had appeared, and all of them cleared. Again, this year we had a large number of children who had appeared for neuro-ophthalmology. And as I mentioned, it's a growing, interesting subspecialty. As mentioned, none of us really do neuro-ophthalmology per se absolutely individually in India. Most of us anyway have to do adult cataract, considering the volumes that we have. So it kind of helps us to sustain ourselves even when we are in practice. But institutionally, of course, that's one place where neuro-ophthalmology tends to have its area where fortunately or otherwise, we get a lot of patients who may not later on turn out to be of neuro-ophthalmology origin. So these are some of the earliest publications. You can see in 1987, one of the earliest publication by Dr. Nachir from Arvind I, who published on neuro-ophthalmology. I couldn't get earlier, but many of them were probably not available on the PubMed, so I don't know for sure. But these were among the early neuro-ophthalmology publications. You can see that we've had publications in 1987, 1989. So neuro-ophthalmology development goes a pretty long way in India. We've had the AIOS Times, and now it's been shifted to a journal. Dr. Ashman is the editor of the journal, and we hope for some wonderful publications. We look forward for contributions from everyone so that we can, it'll be available online so that anybody can access it, and we'll be, of course, hoping for contributions from everywhere. We have over 500 indexed publications from India in neuro-ophthalmology itself. So as I mentioned, it's growing, a lot of publications. The best thing that came was the study that we had, the QUARK study that brought neuro-ophthalmologists all together actually, and made us, you know, interact with each other, and subsequently we've had a lot of group discussions. Unfortunately, it is yet to become a popular specialty. It's probably not possible to practice it all alone. It has to be part of a multi-specialty hospital, and of course, we all understand that the costs are increasing tremendously. India, again, like much of East Asia, South Asia, suffers from the problem that patients are not covered by insurance, and a lot of payments are out of pocket. So obviously a lot of these investigations being expensive. We had this wonderful paper about neuro-ophthalmology career in the Indian Journal of Ophthalmology, which, while the title sounding as if, the opening sounding as if it was not good, but the end was that yes, neuro-ophthalmology is possibly a career you can actually think of. Currently, it's like the van that comes every morning. So as I mentioned, whenever somebody doesn't know what to do with that patient, you know, the best way is send it to them. If it's theirs, they'll keep it. If it's not, they'll refer them to the right place. So we are the guys who get paid for, according to some of the cornea cataract refraction, cataract and refractive surgery people, we get paid for pursuing our hobby during working time. So that's how it is. But I would say that the one thing that India still lacks is a closer coordination with neurologists. Of course, with due apologies to the neurologists in the room, many of the neurologists don't take us very seriously also. So that's the fear with a lot of ophthalmologists here in the room, that, you know, neurologists tend to kind of look down on you guys and say, you guys don't know enough. So, but that's okay. The journey ahead is we need to popularize. Like I mentioned, we need to work together to ensure there are a lot of patients that get wrongly referred, that don't get recognized. I mean, I know that in India, because we have such a huge population, we have a lot of patients, and that is why there is an increasing interest. And I'm sure when you come here, when you come for the AIOS, or when we hold the ASNOS, you will have a lot of people coming for the conference, and you will have some interesting questions to answer. So I really hope that this is, neuro-ophthalmology is the idea whose time has come, and I hope and expect that the society, both Indian neuro-ophthalmology and Asian neuro-ophthalmology, would go from strength to strength. Thank you very much for your attention.
Professor Kashi, please.
I have a burning question concerning neuro-ophthalmology fellow training program you showed one slide. And
the training programs?
Yes, training program. And there I saw some NANOS logo there. Are you collaborating with training with NANOS people, or what does that mean, the NANOS logo there?
So the NANOS logo was that we have webinars and teaching programs with NANOS, but of course we don't have currently any fixed teaching program with NANOS.
So
but
collaborating with the NANOS people.
But yes, with individual NANOS.
So in the future, really, we'll be able to organize some fellowship training programs collaborating with NANOS. That would be a good idea.
Absolutely.
Thank you.
Yes. Thank you.
I just wanted to make a comment about what you just said. Yes, that's I think a great idea. So I know that U.S. You need MLE, U.S. MLE to at least most institutions. You need that before you become a fellow. But a 3-month observership, which you know in neuro-ophthalmology you can do a lot because you can see the OCT, visual field. You don't have to cut like to learn. That is allowed at many institutions through, for example, IOFF funds some. So if you have a fellowship training program that you want to send over for 3 months, you know, that would be a good way to collaborate. I think.
Well, as far as JNOS concerns, during the initial period of time when I started working in Asia, actually NANOS really helped us a lot, especially Dr. Keltner, Neil Miller, and Jonathan Traube. These 3 people are truly involved in organizing works in Asia. And that's why we now realized Kalman organized the works in Asia by themselves. But for the previous meetings, usually some center organized neuroradiologist and neuropathologist provided from the ASNOS Center. But the last time, truly, Kalman organized works in Asia independently. So whatever we may say, NANOS contributed a lot to our Asian neuro-ophthalmology. So we really appreciate it. And in the future, truly, as Rohit showed, like truly skill transfer training programs we should develop, collaborating with each other. That's what I think.
Thank you. Thank you, Dr. Satoshi.
Thank you. So that brings us to the last talk of this session. This will be a talk by Dr. Professor Wei Shihui, who is going to talk about neuro-ophthalmology in China. Unfortunately, he's not able to join us in person, but he has submitted a recording. So let's play the recording.
Ladies and gentlemen,
Audio.
I'm Shi Wei from PLA General Hospital of China. It's a great honor to be here. Today, my topic is about optic compressive neuropathy associated with anterior glenoid process pneumatization. Conflict of interest now. Case 1, man, 60 years, TT amaurosis from the left eye, every morning for 3 years. The amaurosis lasts 2 to 3 minutes every morning after he getting up, and it resolves itself 1 hour later. During the course, no visual change. Eye examination, OS, RAPD positive, anterior segment and the fundus is normal. OCT, GCL of left eye was less than right eye. RNFL of left eye was thinning than right eye. Inferior visual field deafening for the left eye. The broadening of the optic nerve sheath on the left eye and the lateral sphenoid sinus of optic canal expanding. The sphenoid sinus cyst on the left side far from the optic nerve. HRCT, optic canal CT. Sphenoid sinus calcification expand to anterior glenoid process pneumatization on the left eye. Optic struct pneumatization on the right side. Hypothesis. Since the optic nerve was enclosed, contact with the air within the sphenoid sinus, when the hyperrated anterior glenoid process may develop beyond its normal anatomical boundary, it was easily leading to pathological compression. Sudden change in attitude or intrasinus bursts have been proposed as potential triggers for the acute clinical manifestation into amaurosis fugax. Case 1 summary. Diagnosis: optic compressive neuropathy for the left arm, bilateral pneumatization of the anterior glenoid process. Treatment: highlighting prevention, avoid holding breath and coughing, avoid activity with a change in eye pressure like deep diving, swimming, flying, reducing trip to the high altitude area, regular follow-up. Let's see case 2. This is man, 27 years. He presents with progressive painless right monocular visual loss. BCVA of his right eye was 0.3, where that of left eye was 1.0. RAPD was positive for the right eye. OCT indicated GCL of the right eye was less than the right summary. Diagnosis: optic compressive neuropathy for the right eye. Diagnosis 2: bilateral pneumatization of the anterior glenoid process. Treatment: highlight prevention, avoid holding breath or coughing in accident. Avoid activity with change in the air pressure like diving, swimming, flying, etc. Reducing tree to high altitude areas. Regular follow-up. Here are some questions. For the pneumatization of the anterior glenoid process, what's this? How's it formed? And what's the mechanism of the compressive optic neuropathy induced by ACP pneumatization? The clinical manifestation. Treatment. Today, we focus on the optic pneumatization of the anterior glenoid process. Here we can see the anterior glenoid process. This is medial projection of the left sphenoid wing and lateral walls of the optic canal. Here and here is pneumatization of the anterior glenoid process. Clinical presentation of the compressive neuropathy induced by ACP pneumatization include traction, amaurosis, visual field defect, progressive and painless, visual loss, blocking. The etiology and the pathogenesis remain clear. According to CT scan, ACP pneumatization can be sorted into 5 types. Treatment. No consensus here now. Only some cases reporting. Our hospital initiated retrospective single center research. The goal of our research was to explore the diagnostic characteristic and the prognosis of the CON caused by ACP pneumatization. Clinical information were respectively that those in hospital diagnosis. Alongside the CON company with the ACP pneumatization at Neuro Ophthalmology department at Chinese PLA General Hospital from January 2021 to August 2023. Overall of 16 suffering, 3 females and 10 males. 16 involved eyes. Among the 10 patients with bilateral pneumatization, only 3 induced bilateral CON. When waking up every morning, 2 patients experience several forms of the traction amaurosis in both eyes. 84.6% patients had positive RAPD. 68.5% patients had abnormal optic disc, including 2 optic atrophy, 1 baby temporal optic disc, and 2 swelling discs. Pericapillary circular OCT scan revealed Here we observe interesting phenomena. Patient 1 manifested flatter visual field of the left eye. Here is first and then this is last one. 5 patients, 8 eyes, presented with broadening of the optic nerve feature within T2 WI. Long T2 weighted hypersignal and healing could be seen in 3 eyes in 3 patients. Pneumatization decrease was classified on the basis of the volume of pneumatization into 5 types. Type 0 occurred in 16.5%, type 1 30.8%. 5 patients were under medication treatment with vitamins and nootropic drugs. Patient 8 and 9 were performed with the operation of endoscopic sphenoidotomy and optic canal decompression. In our study, patient 8 with several visual loss in unilateral eye underwent nasal endoscopic sphenoidotomy and optic canal decompression. This is founder's photograph shows pre-operative and post-operative image evidence for patient A. Here and the OCT image and visual field. Limitation. First, changes in evaluating the prognosis were caused by limited sample size and follow-up duration. Second, the mechanism of CON was unknown. For those with pneumatization of the anterior glenoid process in both eyes, but only one eye developing the disease. Third, the relationship between the decrease of anterior glenoid pneumatization and visual impairment was unclear and not elaborated in text. Conclusion. The compressive optic neuropathy caused by ACP pneumatization has around great concern among neuro-ophthalmologists. Our study firstly demonstrated the clinical feature of compressive optic neuropathy due to pneumatization within the ACP region. Further research with a more extensive sample size and extended follow-up period is necessary to validate our results. In summary, CON caused by ACP pneumatization can lead to chastened visual obscuration, varying degrees of visual field defects, and visual loss. HRCT is advised in cases of unexplained visual loss and visual field defects to determine whether or not ACP pneumatization is occurring. There is still no consensus on how to manage these patients. Where it required surgery intervention and its effectiveness still require large-scale research and verification. Finally, I
Thank you for being with us and stay here now. And because of time limitation, we are going to close this session. And we invite all the speakers and the chairman come to forward and for a group photo.